Thanks for the introduction. It's great to be here. The agency medical directors group really has been in the forefront of trying to address the issues with opioids. I started in on this 10 or 12 years ago when we first started looking at the data and realizing that there's some problems here. And Gary and others probably remember people would get very angry when we would say, hey, maybe you shouldn't be, cranking up the dose, on everybody, and maybe we should be a little more cautious about how we prescribe. People would yell at meetings and things like that, and national meetings. So we've really come a long way, over the last 10 or 12 years. I didn't expect this to be the main focus of what I did, but it is now. So it probably will be for the rest of my career. So I'll be talking about the evidence more from a clinical perspective. So the clinical studies, Amy was kind of talking about some of the epidemiologic data. I'll be talking about clinical research that has been done on tapering methods and strategies and outcomes related. Unfortunately, the data is not great. There are a lot of evidence gaps that we will outline. My funding is from federal agencies and professional societies, no industry funding. I am a primary care provider, so just kind of starting off with a case. This is a patient that I've been seeing for probably now about 15 years. She transferred care to me, so this is a patient I inherited, so this is not particularly uncommon. Lots of reasons for pain. She had a pretty severe avascular necrosis related to steroid use, undergone shoulder replacements, hip decompression, hip replacement. In addition, fibromyalgia, non-radicular low back pain, chronic headaches, so kind of a multi-pain thing that we often see as primary care docs. And then also some psychiatric issues, including depression and fatigue, and unfortunately some domestic partner violence stuff going on as well. And also gastroparesis and irritable bowel syndrome, perhaps related in part to the opioids. So she came to me on immediate release morphine, 30 milligrams, 5 tabs a day, so 150 milligrams, Q8 hours, oxycodone, 5 milligrams, 8 tabs a day. 8 tabs at a time, so 40 milligrams every 6 hours. I mean, these are, pill bottles with 300, 400, pills of oxycodone. This was not that uncommon, 7 or 8 years ago. Her MED per day calculated to almost 700. Again, this was on the high end, but we certainly saw people on higher. I mean, we had people on up to 1,500 or 2,000 milligrams a day. She was also on modafinil, on some other medications. Pain, 6 out of 10 on average with day-to-day fluctuations. Pretty much impossible to know how the medications are working for her, right? This is a patient that comes to you, you're trying to get a sense, is there been any functional improvement? She can't even remember a time when she was on opioids. She did say that, the opioids allowed her to carry out her ADL. This is what we always hear, that, I can only function because I'm on my opioids, but we really have no comparison at this point. So this is a patient that I saw, trying to figure out what to do with her. I was uncomfortable with the amount of opioids she was on and trying to think about how to approach that. So just a little bit of background. You guys all know this. We were using a lot more opioids. This happened over a very short period, a 10 or 15 year period, where opioid use, essentially tripled or quadrupled in this country. So we've created this population of patients on long-term opioid therapy. These patients are on opioids for years, if not decades. The doses are often above the threshold suggested in the CDC guideline, 50 to be cautious, 90 to avoid. And we know that long-term opioid therapy is associated with a lot of side effects, morbidity, and overdose deaths. Some of these risks appear to be dose-dependent. If you look, this is one of the things that surprised me when we started looking at the evidence, is that when you actually look at the benefits of opioids, they're actually quite small. They average about 0.5 to 1 point on a 0 to 10 point pain scale versus placebo. So you're talking about half a point difference in pain relief. And this is that short term. We know that with development of tolerance and all these other things, that those benefits are likely to wane over time. We're talking 8 or 12 week studies. So these benefits are not big. It's surprising, when you start to look at other medications for pain, that the benefits are essentially the same, right? So if you look at NSAIDs for chronic pain and other medications, it's always 0.5 to 1 point on a 10-point pain scale. And so this perception that opioids are highly effective for chronic pain is really not borne out by careful looking at the data. We know that opioid use disorder occurs in a subset of patients. We know that quality of life may be adversely affected by opioids, even when patients say that their pain is better. The gastric side effects, the cognitive side effects, the sedation, kind of the subthreshold withdrawal, all these things that we see in these patients, the dysphoria, etc. This slide just summarizes some of the data we looked at for the CDC guideline, looking at the association between higher opioid dose and overdose risk. Amy, I think, talked about some of the caveats. There is potential for residual confounding, etc. But all of these studies try to adjust for use of other medications, comorbidities, the factors that you can adjust for in administrative databases, and they consistently show that at higher doses, the risk goes up. So there are tapering recommendations. The CDC has a recommendation on tapering, so Debbie mentioned this earlier. The recommendation says that benefits do not outweigh harms of continued opioid therapy. Clinicians should optimize other therapies and work with patients to taper opioids to lower dosages or to taper and discontinue opioids. The CDC guideline says 10% reduction in initial dose per week. It means 10 weeks to discontinuation. That was noted as a reasonable starting point. As Debbie says, we also say that some people may require longer tapers. As a primary care clinician, 10 weeks to a taper to getting somebody off opioids just seems completely unrealistic. So with experience, we've learned that some of these numbers need to be adjusted. AAFP suggests 10 to 20% every 1 to 2 weeks, and then it adjusts according to response. The VA says most commonly tapering will involve dose reduction of 5% to 20% every 4 weeks. So what's the actual evidence on this stuff? Let's talk about, so the CDC guideline also mentions tapering indications. So when do we taper? Right, so patients don't have sustained clinically meaningful improvement in pain or function. Again, this can be very difficult to know when you're inheriting patients. Even your own patients, trying to look back 5 or 10 years and trying to figure out how they're doing now compared to then. If they're on higher doses and the benefits don't outweigh risks, if they're on other medications, i.e. benzos, that increase risk and can't be tapered off. If the patient wants to taper, that's great. We should work with them to do that. If patients have had a serious event, like an overdose event or another serious adverse event, the CDC guideline, just to reiterate, does not say to taper all patients on higher doses or to taper all patients with specific pain conditions. There's nothing in the guideline that suggests that. So some of the, as Debbie and others have mentioned, some of the policies that propose to do those types of things are not consistent with the guideline. The VA also has an opioid taper decision tool, so they have a number of factors. These are similar, I would say these are consistent with what the CDC guidelines thinking about risk versus benefits and who should be tapered. So there's many ways that we can actually evaluate opioid tapers. So I'm just presenting this slide to kind of illustrate that this is a pretty complex issue, and there's a lot of ways we can try to think about, how to taper, what are the effects of tapering. So we can compare tapering versus not tapering or usual care. You can look at slower versus more rapid tapering. We can look at tapering with adjunctive therapies, varenicline, antidepressants, acupuncture, whatever, other things that may be adjunctive to help patients taper. You could also look at clinical systems and kind of systems of care and how those might affect the taper. The adjunctive treatments can be pharmacological or non-pharmacological. We can compare, use of an adjunctive treatment versus no treatment, or alternative adjunctive treatments. So there's many different comparisons we could look at. There's lots of different outcomes. Being patient-centered, we want to understand how tapering affects pain, function, quality of life, psychiatric outcomes, including suicidality and suicide events, how effective the taper actually is at lowering the opioid doses, and how effective we are at getting people off opioids if that's the goal. Presence of withdrawal symptoms, opioid-related adverse events, and then overdose, opioid misuse, and mortality. As Amy mentioned, some of these outcomes are very hard to evaluate because they're rare. And as I'll show you, many of these studies are not, the sample sizes. These are pilot studies. The sample sizes are just not there to be able to look at some of these very important events. Just want to mention also that there's a lot of potential modifying factors that we have to think about. That it's not a one-size-fits-all kind of thing. That the patient demographics, age, sex, other things, pain type, how high an opioid dose they're starting on, or what type of opioid, a partial agonist versus a full agonist, etc. What the indication for tapering is, the willingness to taper, presence of psychiatric comorbidities, substance use, medical comorbidities, and then the clinical context. Are you prescribing or trying to taper in a rural setting where you have basically no support, or are you doing it in a academic tertiary care system where you actually have a lot of coordination and lots of support? These can probably impact the effectiveness of these different strategies. So very complex issues, and I'll say that the data is not particularly strong at this point. So we do have a few studies that have tried to look at tapering versus no taper. As you can see, the sample sizes are quite small, so 12 and 35 patients. These studies also have methodological limitations, including very high attrition or crossover. At this point, are not particularly helpful. There's a study done by Karina et al. Published last year, 35 patients who were first stabilized on higher doses of opioids. Then they were tapered by 10% weekly to cessation, given quantity for withdrawal, or essentially maintained on their opioid dose. At baseline, the doses were 367 versus 221 milligram morphine equivalents per day. They plan to report outcomes at 6 months, but they only reported outcomes at 4 to 6 weeks due to high attrition. Only 1 out of the 15 patients in the intervention group actually completed follow-up, but only 12 out of 20 in the control group. So this is problematic. The opioid doses were lower in the intervention group, but not statistically significant, so 227 versus 301. And they actually started higher in the intervention group. The pain scores were a little bit higher in the intervention group. Again, this is all at 4 to 6 weeks. No real difference in anxiety or depression scores. There was another very small pilot study done by Blondell et al. With only 12 patients. These were patients who had chronic pain and prescription opioid dependence. They were all transitioned to sublingual buprenorphine and then randomized to taper versus maintenance. Basically, everybody in the taper arm crossed over to maintenance or they relapsed. And so they just stopped the study. So really, again, unfortunately not very helpful. One earlier study by Cowan et al. In 2005, they abruptly stopped morphine and those patients had more withdrawal, so this seems obvious. They did not apply any type of tapering protocol. They only looked at 60-hour outcomes. There is a study led by Mark Sullivan, who is here, on taper support versus opioid treatment as usual. This came out 2 years ago. Again, another pilot study, 35 patients. They looked at a 22-week taper support intervention. This consisted of psychiatric assessment, weekly sessions. I think they were with a physician assistant. They did motivational interviewing, self-management training, versus continued opioid treatment as usual. I think some of the caveats with this study is the patients had to be willing to taper. I think initially they had to be willing to taper at least 50% to be entered into the trial. I think they changed some of the criteria later to loosen that up. And also this was done at University of Washington where, again, this is probably not the same type of clinical context as you might see in a lot of other settings, where there's been a lot of work done in trying to reduce harms of opioid use. At baseline, patients were on 226 milligrams morphine equivalents per day. At the end of the taper support intervention, at the end of the 22 weeks, there was no statistically significant difference in pain severity, though it slightly favored actually the taper support group. There was a slight better effect on the BPI pain interference result, again favoring the taper support intervention group. Also fewer difficulties with prescription opioids. This is based on this POD scale. And there was a non-statistically significant lower opioid dose with the intervention. These effects persisted at 34 weeks. So I think the main takeaway from the study is that using this taper support intervention did seem to be associated with some, at least modest, better outcomes in patients who are willing to taper. This issue of slower versus more rapid taper, almost all the recommendations I presented, the recommendations from the CDC guidelines and others, these were almost all entirely based on patients with opioid use disorder related to illicit heroin use. So these aren't people necessarily with chronic pain, and I think that really probably changes the equation. So, all this stuff about being able to get people off opioids in 7 weeks, these are people with, heroin addiction, where you probably can do that as long as you're treating them appropriately for their addiction. There's very few studies on rapidity of taper. There's a cohort study done by Mark et al. This is of Medicaid beneficiaries in Vermont. These were patients prescribed opioids at over 120 milligrams morphine equivalents per day for over 90 days. Some of these results are pretty astounding. The median time to discontinuation was 1 day, right? So half of the people were just taken off of opioids. 86% discontinued within 21 days, right? So I've never tried to taper that quickly in my practice, but this seems to be routine at least in this setting. And these are not people on low doses. These are not people who have just been, discharged on opioids for surgery or whatever. So this is happening out there, that people are being abruptly taken off opioids. They did try to do an analysis to look at, how long the time to discontinuations of kind of a proxy for taper length, and how that impacted risk of opioid-related ED visits or hospitalizations. So for each additional week, essentially, that to discontinuation, the risk of having an ED-related visit was 7% lower. And but you're still talking about, we're still not even getting to kind of normal recommended durations of tapering. Another thing to note in this study is 60% of the patients with substance use disorder prior to tapering, but less than 1% received medications for opioid use disorder. The main thing I take away from all this is that people are not, tapering appropriately. This is not the way that we recommend that tapering be done. It'd be like, somebody with hypertension and just sticking them on, the highest maximum dose of a medication right away. It's just not, how practice is meant to be. But it does tell us that there are these things going out there and that we need to be aware of them. And we need more studies to understand optimal tapering protocols. I think Debbie or Amy showed this earlier. This is all consistent with the FDA warning that was released a couple months ago. We do also have a study on adjunctive varenicline, so using this as a kind of adjunctive therapy in patients undergoing tapering. This repeats the slide earlier, but there was a small study that looked at the use of varenicline as an adjunct to tapering. Did not show significant benefits. There are a lot of other potential therapies that could be used as adjunctive therapy and tapering, and they just have not been studied rigorously in clinical trials yet. There's an older study that looked at tapering plus counseling versus kind of a less strict tapering regimen where they would try to taper people, but if they couldn't, then they would just maintain them. This was 42 patients who volunteered for withdrawal. They underwent detoxification plus counseling over 3 weeks, again very fast, or what I would consider very fast, versus detoxification with maintenance, and detoxification was unsuccessful. The doses at baseline varied widely from 240 to 2,400 milligrams per day of codeine. The outcomes they looked at were pretty limited. They looked at how many people completed the 3-week intervention. The detoxification, there was a lot fewer patients that completed in that arm, so 24% versus 95%. And then the proportion abstinent after 6 months, there was no statistically significant difference, but the results were a little bit worse in the 3-week taper arm. A couple of years ago, there were some studies that have tried to look at outcomes of tapering or discontinuation, so not really doing these comparisons like we were talking about, but just looking at, so if somebody comes off of opioids, how do they do, right? So this is a systematic review by Frank et al., published in Annals of Internal Medicine in 2017. Studies really, this evidence is actually quite limited. These are mostly observational studies, generally using a pre-post design, so just compare people how they were before the taper versus after the taper. The studies have a lot of methodological limitations, including a lot of attrition. There's a lot of self-selection, obviously, so people who want to taper are more likely to be successful at it. Tapering was not the purpose of a lot of these studies, so in some of these studies it was another intervention. They received like multidisciplinary rehab or something, and some people happened to come off of their opioids, so the purpose wasn't to actually taper them. And they rated the evidence very low quality for all of the outcomes they looked at. The good news is that the outcomes do seem to be favorable in people that were able to taper or lower their dose. So pain severity, 8 out of 8 fair quality studies, and most of the poor quality studies reported improved pain. Function, you kind of see the same pattern, as well as for quality of life. For opioid withdrawal symptoms, the estimates are all over the place. These are hard to standardize, and the studies vary in how they look for withdrawal symptoms, but 0 to 100%, so pretty much the biggest range you can have. 4 of the studies reported withdrawal in all patients. 2 studies reported illicit substance use in 63 to 64% of patients. 1 study reported non-medical use of prescription opioids, and 1 study reported illicit IV opioid use in less than 1%. Again, not well standardized in terms of how they're looking at that outcome. And then 1 opioid-related overdose was reported in 5 studies. Another systematic review by Fishbane found that 85% of studies showed improved pain at tapering completion, 15% the same. So at least people, based on this pretty low quality evidence, don't seem to be worsening in terms of their pain. I wanted to mention kind of this concept of voluntary tapering, which has been, I think, gotten some traction in terms of policy, and we shouldn't be involuntarily tapering patients, that kind of thing. A lot of this seems to be related to this short piece written by Beth Darnell in 2018. They had a series of 82 patients who received education about the benefits of opioid reduction, and then these patients agreed and volunteered to taper over a 4-month period, not necessarily off opioids, but to lower doses. At baseline, the patients were on almost 300 milligrams morphine per day. The duration was almost 6 years, so these were patients on chronic opioids. The tapering plan was to reduce by up to 5% for up to 2 dose reductions in the first month, and then up to 10% per week. 38% dropped out prior to 4 months, so over a third of the patients. And you can see that they were able to lower the opioid doses to 150 milligram morphine equivalents per day, but obviously not off. The pain was similar in people who were able to completed the study compared to baseline at 4 months. no change in pain outcomes, and then or an anxiety, depression, or sleep disturbance. I think some of the issues with this study is that yes, the outcomes look pretty good, but you have pretty high dropouts, and these are self-selected patients, right? I mean, if I have a patient that comes to me and says, I want to taper, I know they're going to do pretty well, but that's not the average patient. Most patients don't want to taper, or they're very fearful of tapering, and we're having to help make these decisions. There's also, I think, this issue of how do you actually measure voluntariness, and how do we actually assess these effects of voluntariness. I mean, I actually really don't know how to do this. If I think about my own patients, they really vary in their motivation and their willingness to taper, and some of this really is a medical decision. That the risk outweigh the benefits, and I have a hard time understanding actually how to operationalize this concept of voluntary tapering. So that's the evidence. So again, it's not great, but I think it's worthwhile understanding where we are at this point. I wanted to note that there are some tools and kind of approaches out there for thinking about tapering. This is a Bravo approach developed by Anna Lemke and her group at Stanford. That's an acronym. It's hard to read some of these words, but the B stands for broaching the subject, the R is risk factor calculator, A is addiction happens, B is velocity matters and validation, and O is using other strategies for coping with pain. I think it's a nice framework for kind of a patient-centered approach for tapering. It has not been evaluated in clinical studies that I'm aware of, but probably should be. And then we have the Oregon Pain Guidance Tapering Flowchart. So there's materials on the Oregon Pain Guidance website on tapering and kind of a way to think about tapering. This does bring up some of the issues that I think Ian will be talking about later about patients who may not meet criteria for opioid use disorder but have persistent difficulty tapering, what we call complex or persistent opioid dependence, and whether you consider use of buprenorphine in those patients, and kind of there's this emphasis on slowing down the taper, which in many clinicians' experience is kind of the biggest problem. If you try to taper too fast, that's when you run into issues. So kind of going back to my case, so this was a patient on high doses. It was unclear to me if she was benefiting from the high doses. I thought that her GI symptoms, she had gastroparesis, her irritable bowel might be getting worse. She had a lot of psychological comorbidities. There was some polypharmacy. There's no signs of aberrant behaviors, but my overall assessment was I don't know if the benefits outweigh risks, and I thought they probably didn't. We started a slow taper. I mean, this is I took over practice for a guy who was like 70 years old and retired, and I was like the young guy coming in. So it took a while to kind of develop some rapport and for her to kind of trust me. But after a while, we started on a slow taper. This happened over about a 2.5-year period. So this was a slow process. We were able to get her morphine down from 450 milligrams a day to 75 milligrams a day, and her oxycodone down from 160 to 40. So this was an NED reduction from almost 700 milligrams to 135. We added some non-opioid medications, including duloxetine and buspirone. Pain and function really no worse than what she was on high doses, no serious withdrawal. I would consider this to be a success. So in conclusion, evidence on effects of opioid tapering in persons with chronic non-cancer pain remains limited. We have some evidence to support use of taper support interventions, some evidence that abrupt discontinuation is associated with worse outcomes, data on optimal taper speeds otherwise is not available. We have very low quality evidence that patients who taper opioids may experience improved pain and function, or at least not worsening. The studies were not designed to evaluate some of these important outcomes like overdose risk, use of illicit opioids, suicidality. Again, it would be very difficult to do this in an RCT just because of sample size limitations, and I showed you all the problems with crossover and attrition. We need research on effectiveness of adjunctive treatments, buprenorphine taper versus maintenance, effects of patient and clinical factors on taper outcomes. And this is one of my sons. This is when we were in Greece in March, climbing